Good morning, everyone. Good afternoon. Good evening. Thank you very much for finding time to join our webinar this moment. Feel welcome, everyone. My name is George, and I'm taking you as your moderator today. Today, we have an exciting topic, and we are calling each and every one of you to invite your friends even as you join, so that we can learn accordingly. And so at this time, we are time barred. I hope that the presenter screen is is visible, and you can actually see it clearly. So today, we are joined by an experienced medical laboratory practitioner who is having a wide experience and knowledge in matters virology. And our presenter is Nashon Ouko, who has undertaken BSc in medical laboratory sciences, and is also undertaking Masters of Science in virology. And Mr. Nashon is also a member of Nyanza Western HIV Technical Working Group. And in his field, he has tackled and is tackling lots of virology works. And so today, as I've just said, we have an exciting topic on understanding HBV testing in the triple elimination agenda of vertical transmission. And so at this time, I hope that Mr. Nashon is here and you can hear me. If you can hear me, Mr. Nashon, you can just
Yes,
confirm.
I can hear you.
Great. Over to you. So proceed.
Yes, good morning, afternoon, and evening, depending on your time zone, colleagues. Welcome to this presentation. And we have a topic today that we are going to discuss that is trendy, very important. That is understanding hepatitis B virus testing in the triple elimination agenda of vertical transmission. My presentation outline, my co-host, I hope you will be helping in moving the slides. Kindly move to the next slide so that the viewers can see. We move together. Yes, perfect. Thank you. So my presentation outline is embedded in understanding the triple elimination. That is elimination of mother-to-child transmission agenda for HIV, syphilis, and hepatitis B virus. So these three threats, we call them the triple threats to mother and child. We are here to slay the dragon of both HIV, syphilis, and hepatitis B so that it can be eliminated amongst our population, and most importantly, our mothers who are giving birth. And the second presentation outline is to get to know when and why to screen pregnant and breastfeeding women for hepatitis B surface antigen in Kenya, and then to introduce rapid HBsAg, rapid testing, procedure, interpretation, document, and act on results within the PMTCT cascade. Next slide. So what is the goal of triple elimination of HIV, syphilis, hepatitis B agenda in Kenya? So the goal is to raise a generation born free of HIV, syphilis, and hepatitis B. Then we are determined to integrate ANC services. That is, a single visit, you should be able to get multiple tests. And the multiple tests are aimed at eliminating the three HIV, syphilis, and hepatitis B. Then we have key pillars of primary prevention, timely testing, effective treatment, also prophylaxis, and timely data reporting through our reporting site, that is KHIS. So HIV, HBV, and syphilis are diseases of public health concern. And on maternal testing of HIV, HBV, and syphilis, it's very significant because these three, they cause perinatal morbidity and mortality. So perinatal HBV infection results in high risk of chronicity and future hepatocellular carcinoma. Now, HIV and syphilis, as we are all aware, continue to require vigilant ANC screening and linkage. 90% of HBV are HBV exposed infants. Under 5% develop chronic HBV. Triple EMTCT aligns with the Kenya's integrated PMTCT and maternal neonatal child health priorities. A failure to detect and treat HBV and HIV among the pregnant and breastfeeding women results in high HIV and HBV viral loads. And when the viral loads of both HIV and HBV are high, we all know it increases the risk of vertical transmission. And vertical transmission, I hope we are all aware, is the transmission from the mother to the child. That is either before the child is born, when still in the womb, or during delivery, or during breastfeeding. So the transmission of disease is similar during pregnancy and also delivery. So we understand that HIV, the rate of HIV vary between 20 to 35% in breastfeeding infants, or 15 and 20% for non-breastfed infants minus intervention. So if you don't give intervention, then the rate varies and increases depending on the intervention that you give. So with the intervention, these rates can be effectively reduced. And that's why we are all aware that we are bringing in these interventions of testing. We are bringing in the interventions of vaccinating to ensure that we reduce the risk of hepatitis B. So what is the HBV global epidemiology? 254 million people were living with chronic hepatitis B virus in the year 2022. We had 1.2 million new infections each and every year. Now, viral hepatitis is responsible for estimated 1.3 million deaths in the year 2022. And 83% was attributed to hepatitis B virus. Increase in estimated mortality since 2019 suggests increasing number of hepatitis-related cancer cases and deaths. So we have around 1% HBV HIV co-infection. And the global prevalence of HBV infection among people living with HIV is 7.4%. Remember, only 13% of people living with hepatitis B virus are aware of their infection, which is very dangerous. And only 3% of people living with HBV were on treatment as of 2022. So you can see how detrimental this virus is, having it and not knowing that you have it, and not just not knowing it, that you don't have it, but also failing to seek treatment. So you have it, you're not aware. Those who are aware are also not seeking treatment. So it's really a sad state of affair. Then HBV can be prevented by vaccines that are safe, available, and effective. So I believe in most of our facilities, we have this vaccine. I'm not really certain, unless if we would have taken data, but I believe under our expanded program on immunization, HBV vaccine to our children are there. Then the regional epidemiology of HBV. There exists regional variation in the viral hepatitis burden and response. The World Health Organization African region accounts for 63% of new hepatitis B virus infections. That 18% of newborns in the region receive the HBV birth dose vaccination. So just imagine 18%. So we have around 82% that did not receive. So the question I did post there is, does your facility offer the vaccine? Now Africa accounts for 70% of the global HBV cases. So 30% is shared amongst the other continents. So we can see Africa has the largest burden of HBV. And these cases are found among children younger than 5 years. So averagely 4.5 million African children have chronic hepatitis B virus. And the coverage for routine childhood vaccination against HBV is 72% in Africa. Way below, we have a target of 90%, just like we have HIV triple target of 95, 95, 95. So we have a global target of 90% for vaccination against HBV. But we are still way below, we are 72%. So we need like 12 more percent in Africa to achieve the target. And in 2019, only an estimated 2% of persons infected with HIV were diagnosed and only 0.1% were treated. So you can see how worrying this trend is. Globally, 10% diagnosed and 2% treated hepatitis progress report. So the progress report of 2019 shows all that. So in our country, Kenfia, we all know about Kenfia. Unfortunately, the last Kenfia data hasn't been collected. I think it was supposed to be late last year, but I can't tell. Maybe moving forward, it will be done. But as you can see from the screen, we have 3 regions that have high burden of hepatitis B. That is the Northeastern at 7.6%, Rift Valley North at 5.0%, and Nyanza at 4.6%. This is Kenfia 2018 report. A 3% national weighted prevalence as at 2018 report. Then the HBV co-infected people living with HIV on ART was 72.7%. We had counties that had the highest prevalence that include 11.9% Baringo, Migori at 10%, and Turkana at 16.8%. And this higher burden of HBV was reported among the ages of 45 and 49, which had 8.5% prevalence, and the ages of 20 to 24 had a prevalence of 1.5. Based on gender, we had 2.8% were there amongst women. Men were 3.3%. 4.2% was there amongst pregnant women, and 4.7% among adults living with HIV. So as you can see, the general population of women was relatively low as compared to the 4.2% amongst pregnant women. This can be explained, I think, largely because most of the pregnant women, they go seeking ANC services, and it is at this point that the HBV testing is done. Amongst the general population of women, mostly the testing is not done to a level equivalent to those that are pregnant. So this can actually attribute to the highest number of prevalence of HPV amongst the pregnant women. So what is the rationale of for the triple elimination? Why? Now, HIV, syphilis, and HPV are transmitted sexually and vertically from the mother to the infant. We're all aware that these diseases can cause significant maternal and child morbidity and mortality, and can be identified during ANC and treated to prevent vertical transmission. So it's encouraging because we have a disease here that can be prevented, a disease is here that can be treated. So the triple diseases are often silent with long latency period, and infected mothers may be unaware and have no symptoms. So this presentation is geared towards our mothers who are seeking for ANC and generally at the MCH. This is the maternal child health. Most, like for example, HPV, most of the people, they have the disease, there are no symptoms. So as we are all aware, when you don't have the symptoms, you don't even see the need of going and testing. Unlike other viruses that their symptoms are quite fast, like the hemorrhagic fever viruses. And that's why the death rate of such viruses are actually high. Unlike this one that doesn't show symptoms for quite a long time, and you only get to know that you have it when you go test it, or when actually the disease has advanced. So we want to tackle viral hepatitis as the next slide. So viral hepatitis, we have almost 5 groups of viral hepatitis. That is A, B, C, Delta, and E. And the grouping is based on the route of transmission. Viral hepatitis A and E are transmitted through contaminated foods and water. That is fecal oral. And they normally result in short-term acute infections. For the viruses hepatitis B, C, and Delta, they are bloodborne and usually result in lifelong chronic infections. Hepatitis B, C, and Delta may lead to long-term chronic infection and death. And all these viral hepatitis viruses cause liver inflammations. So I have a table explaining different hepatitis viruses. Their mode of transmission, the availability of vaccine, and the availability of treatment. So starting with the hepatitis A virus, the mode of transmission is contaminated food and water. It can be vaccinated and it has no treatment. Very important to note. Hepatitis B virus, its mode of transmission is through contact with infected blood, sexual intercourse, and also vertical transmission, mother to a newborn. It has a vaccine and it has a treatment that is long-term. Hepatitis C virus, contact with infected blood, it has no vaccine and it has treatment. Hepatitis Delta virus must already have hepatitis B. That is the mode of transmission. So this particular individual must already have hepatitis B, contact with infected blood. Then there is sexual intercourse and mother to her newborn. That is another mode of transmission. Then its vaccination is, of course, getting the hepatitis B virus, the vaccine, and it has no treatment. Hepatitis E virus, we get it from contaminated water. It has no vaccine and it has no treatment. So these are very important things that we need to know when dealing with these viruses groups. So what are the modes of transmission of hepatitis B? So this is very important. And just like other viruses, hepatitis B virus, you can get it from or through different means. One being sharing needles, that is contaminated needle, a needle that is contaminated with the virus. Then we have tattoos, piercings, those going to the barber shops, scarification, those people who are removing their scars from the skin, circumcision practices, when they are doing circumcision with unsterilized materials, you can contract the virus through that means. Then, of course, vertically through mother to child during birth. We have household items that we normally share, not normally, but some people across some corners and quarters still share these items, like toothbrush, earrings, razor blades to cut their nails, the nail cutters. I hope also when you are using the same knife to cut your skuma wiki is a sharp object, so you should not be sharing that because no one will all actually tell you that he or she has hepatitis B. So the healthcare exposures, we all know if you get into contact with a needle that is contaminated, blood, like the glucometer process of testing RBS, is if you come into contact with that blood, you can be infected. Sex, one thing that people don't want to share, people don't like sharing publicly. People have actually advanced nowadays to disowning the legal and the normal way of having sex using the vaginal route. People have advanced to oral, anal, and any other orifice. Some are even going through the nose and the ear. So long as there is an orifice, the body, they see that as an opportunity. Quite sad. But anyway, what do we say? So unprotected sex, there is a risk during any type of sexual contact. Any type, I had to insist on that. So although HPV can infect fetus in uterus, this is rare. So the transmission generally, when there is a rupture in the uterus, when there is a tear, maybe due to trauma in the placenta. So those are the routes or the ways in which a fetus can actually contract HPV from the mother. The next slide talks about the symptoms. So Africa, we have symptoms that cut across almost in all diseases. So we have the tropical diseases. Once you mention fever, any disease will present with fever, weakness or fatigue. But there are some that are actually can be singled out from hepatitis B. And they include dark urine and or pale poop. When you have the stool that is pale, when you're doing stool analysis, you're doing urine analysis, you see a dark urine, pale poop, and we understand why this, because why the urine is dark and the poop is pale from the liver, the bilirubin, and the rest. So we have fever, we have jaundice, you lose appetite, headache, hives, joint pain, and pain in the right side of the abdomen, because it's at this point, it is at this particular point where the liver is. So less than 10% of people infected with chronic hepatitis B have symptoms. Very, very worrying. And if symptoms occur with chronic hepatitis B, they can be a sign of advanced liver disease. So my next slide focuses on risk factors, HBV risk factors. So the risk factors that are associated with hepatitis B include one, HIV infection, of course, co-infection. If you have HIV infection, you're at high risk of being infected with hepatitis B. Age is quite another issue. From age 45 to 54, you are predisposed. Polygamy, those who are having a number of sex partners. Lack of formal education and poverty. This, I think, compromises someone's judgment. Those who are poor, impoverished, they always become at risk, and they become, people take advantage of them. So when someone is infected and he or she has taken advantage of someone who is impoverished, someone who has no formal education, it's easier because the judgment at that point is low. They might not be able to actually resist. So cultural practices that include FGM, tattooing of the body, this has become a norm. And we've seen how it has actually even been an issue in blood donation. But I've seen also advancing these people after 3 months of tattooing and they've tested, they can still donate blood. I think that right now we know. So we have families with a person. So family history, these are genetic issues. So when one has a family history of hepatitis B, it predisposes someone to hepatitis B. Then needle sharing, and also living in a region that has high prevalence of hepatitis B, this puts you at a risk. Yeah, so who are at risk? The populations that are at risk, one, are healthcare workers. Mostly, we all know as lab professionals, we come into contact with blood so much as one of the specimens that we normally and frequently use. So I've talked of the age, people in close settings, the refugee camps, prison, nursing homes, children's homes, the contact, they actually, the movement, they don't have that freedom of moving, of space actually. That is what I was looking for. So when you don't have space, so it's easier for you to come into contact with someone's fluid and therefore predisposing you to hepatitis B and other bloodborne viruses. So newborns through vertical transmission are at risk. The key populations, the men have sex with men, female sex workers, transgender, people living with HIV are at risk. Patients undergoing transfusions and dialysis are also predisposed. Yes. One thing that is important to note in the next slide is that we are all aware we have hepatitis B. It can be prevented with a vaccine at birth. However, it is sad to note that not all babies that are born receive the vaccine. I was in a discussion somewhere, and the vaccine is quite expensive and its availability, it's not always guaranteed. So these are the things that actually predispose and make our children vulnerable to this disease. And many of our pregnant women actually do not even know they are infected, and they do not even show symptoms. For those who are tested and have been told to have reacted or are having the virus. So it is important to note that without this vaccine, most of these people will develop into chronic illnesses and the lifelong infections. And the virus will advance to advanced viral disease, therefore causing a lot of harm to the liver. So the next presentation is assessment of eligibility for antiviral prophylaxis. So we have prophylaxis for hepatitis B virus. And before you are put on this prophylaxis, you need to be assessed. And the assessment is done, one, there are testing that are done, the DNA, the HBV DNA testing, or the hepatitis B antigen testing. HBe antigen testing, we all know, is a protein that is made by hepatitis B virus, and it appears in blood when virus is actively multiplying. So when it is not available, when the HBV DNA is not available, then it is advisable that the maternal intervention that is offered is tenofovir, others call it tenofovir, prophylaxis to all hepatitis B surface antigen positive pregnant women and adolescents. So when it is available, on the first arm, we can see on hepatitis B virus DNA, when we have a test of less than 200,000 international units per milliliter, or the hepatitis B antigen negative, then there is no maternal tenofovir prophylaxis that is given. But when we have HBV or the DNA, HBV DNA with the test above, equal or above 200,000 international units per milliliter, or the hepatitis B antigen is positive, then the maternal tenofovir prophylaxis is recommended from at least second trimester of pregnancy until at least after delivery. Very important. Very important. So I'll move to the testing. Actually, is the screening for hepatitis B in our maternity. That is in ANC, antenatal clinics. The test kit that has been rolled out by NASCOP is called BioLine. That is currently available, I think, in nearly all public facilities in Kenya, and is the one that is used to help us eliminate mother-to-child transmission of hepatitis B virus. So what is the clinical pathway and linkage of hepatitis B virus? So when we have hepatitis B surface antigen negative, we are advised to reinforce prevention, ensure newborn hepatitis B vaccination as scheduled. When it is positive, we are encouraged to cancel, do baseline analysis of HBV DNA if available, then test for HIV and also screen for infections. So for high MTCT risk, that is, as I had indicated earlier, if the HBV DNA is above 200,000 international unit per milliliter of blood, you're advised to give the TDF, tenofovir disoprosir fumarate prophylaxis from 28 to 32 weeks until at least birth. So infant hepatitis B birth dose is normally given before, at or below 24 hours. Hepatitis B immunoglobulin, if available, then is also given per the policy that is available at the MCH. So we are also advised to document. I think mostly this is done at the TMTCT, because I know it's a bone of contention between lab and nurses. because most of these tests have been migrated to ANC. So mostly the documentation is also done in the NC register, and in the Kenya EMR, also the baby booklet is also documented. So what are the other hepatitis markers and their clinical significance? We had started with the hepatitis B surface antigen, and we all know it's the first marker to appear in course of infection. The hepatitis B surface antigen appears 1 to 3 weeks before onset of symptoms. And when it persists after 24 weeks, then it indicates chronicity, that is going to chronic state. So we also have anti-hepatitis B C IgM, immunoglobulin M. So it's a marker of recent infection. So if you want to know a recent infection of hepatitis B, you go for anti-HBC IgM. It appears with onset of symptoms and persists up to after 32 weeks post onset. Then we have anti-hepatitis B, C, immunoglobulin G. It does not actually indicate immunity and is not elicited by vaccination. We have hepatitis B, E antigen. It indicates exposure to virus, appears before onset of symptoms, and it also indicates viral replication independent of disease phase, acute and chronic. Antibodies BE indicates high infectivity, appears after disappearance of a hepatitis B E antigen. It actually suggests reduction of viral replication, except when infection due to hepatitis B strains with pre-co-mutant. So the last marker is anti-hepatitis BS. It appears 1 to 3 months after hepatitis hepatitis B virus vaccination, or after recovery from acute HBV infection. It indicates immunity to HBV. So this only indicates that there is immunity that has actually been conferred against the hepatitis B virus. So I started on talking about the BioLine kit that has been rolled out by NASCOP. And just like other rapid kits, we might not dwell into it so much. I don't know how much more time is left for me. 3:44. Okay. So most of these test kits and the rapid ones, they normally have test procedures that cut across. But this doesn't mean that whenever you receive a test kit that is rapid, you assume and you don't look at the manufacturer's insert. So the manufacturer's information is very, very important before you start using a kit. We can have different and quite a number of kits that are used to test hepatitis B, but companies have their specific procedures, specific items that are provided and their testing time. So that is why it's very important and not to assume that each and every kit resembles all other kits. So the BioLine hepatitis B surface antigen kit components include the basic ones. Actually, it's a kit that comes that is able to test 30 patients. That is the test kits are 30 in number. It has a manufacturer's insert. So what are the materials that are required and that are provided? So micropipette is not provided. Disposable tips, a pair of gloves you get from your facility, timer pen, biohazard box, disposable bin, These ones you avail them in your lab. Of course, the biosafety and infection prevention, these are and control, these are common things that we all know as lab professionals. And the standard precautions of PPEs, the safe handling of sharps using the safety box, the hand hygiene, very important. Then use of puncture resistant sharps containers if you don't have the sharp box. Then segregating waste, very important for IPC protocols. One thing that I appreciate lab about is the environmental cleaning. You disinfect your bench, you disinfect your materials before and after leaving the lab. Of course, the post-exposure prophylaxis management, all facilities have this displayed. Their walls, it's very important, not only for displaying, but seeking the services once you are exposed. So the test overview of BioLine is obviously an immunochromatographic rapid test, and it's qualitative. It cannot quantify the virus itself, and it detects the hepatitis B surface antigen. So with this kit, you are able to test blood, whole blood, serum, and plasma. And one thing that is very important about this test kit is that the sample volume is 100 microliters. We should be able to understand that this kit has no buffer. And I repeat, this kit has no buffer. So kindly don't introduce your own buffer. You go take syphilis buffer. You go and take any about test kit buffer and come and introduce. Once you have the 100 microliter blood serum or all blood serum or plasma, then you're good to go. The moment you put some blood that is less than 100, the sample will not flow. So I think that we will talk about it when we reach the testing procedure. So the timing is very important in all these kits. Like the twin screen is 12 minutes. So mostly in our ANC clinics, the clinic is populated. Mothers are there, children crying. So you test one and the other one is there. You come and test. You have like 5 tested at the same time. You haven't documented which one at what time. So you come and view your results at 20 or 25 minutes. The line is already there. You're giving false results. So when you say 12 minutes are not longer than 15 minutes, kindly stick to that. This one is specific. 20 minutes, don't go past 20 minutes. You read results at. So the storage is at 1 to 30 and the shelf life is 24 months. So these are common things that you bring the test device and set it into a temperature. That is the room temperature. And keep away from extreme heat and humidity. These ones will actually, they will spoil the kit and give you wrong results. Do not freeze test kits. There is a provided temperature for this kit that should be kept. Our expiry date should be well checked. That is very important thing to note. So what is the test principle? This is actually a lateral flow immunoassay that captures antibodies, bind them with the hepatitis B surface antigen. And the visual line indicates presence. If there's no line, that means there's no reaction that has taken place, and failure to get a reaction means that failure for a reaction to take place denotes a fact that there are no there's no that specific thing you are looking from that kit or from the blood, actually, not even the kit, from the blood, from the sample. The kit is there, but the kit should be able to tell you what you're looking for from the sample that you're testing. So a visible control line is required to indicate a test result is valid. This is actually an internal control mechanism that we all know. Without a test result showing, then that result is deemed invalid. Bioline B surface antigen test, its intended use and target population. So the kit is for in vitro diagnostic use only, in vitro, underline. So the population of interest, usually it's used at ANC and in settings with high hepatitis B prevalence, where we have vertical mother-to-child transmission of chronic hepatitis B, and also along with early childhood infection among those who have not been vaccinated. So this test is not suitable for diagnosis of early infection or blood donation screening. I think we all know this, because when you are, this is actually when you want to detect early infection, then you go for DNA. That is able to tell you, DNA is able to tell you that you are infected from day 7. So it's very important to note this. So the test procedure, just this is the normal ones that we normally have. Opening the package. So the desiccant that is actually supposed to absorb excess moisture, you have to check it if the color has changed. Then the instruction for use. Carefully read the instructions that I said. Each and every test kit has its own manufacturer's instruction that are different from others. You have to check that. Look for the expiry date. You open the foil and you will get the test device and the desiccant. Then you label with the patient name or the patient ID, depending on what you have in the lab or at the NC. And then you must have the pen and the timer. So after venipuncture or whatever blood, the sample you have, you are advised to take 100 microliter of serum plasma or blood using a micropipette. The micropipette is provided in the test kit, and then you dispense the 100 microliter into the specimen well S. S is the sample well site. So you are advised to interpret test results at 20 minutes. Do not read, do not. I hope this, how I wish I would have done it in bold and black and red. That do not read results after 20 minutes. Late readings can yield false results. This we all know as professionals. So the interpretation non-reactive, if there is only a test at the control line, non-reactive. When reactive results, we have the presence of T line, test line, that is on the control line within the result window. Remember, one thing that I normally tell people with this rapid, a line is a line. Whether faint, whether rugged, whether zigzagged, whether what, a line is a line. It actually shows that a reaction has taken place. So na kuna zile, there are some that people normally put them at arm's length and they say, I can see it from far. A line is a line. Invalid results. So if we don't have a control line, that result is invalid. If we only have a test line, that result is invalid. The test kits that we previously had that were showing around 3, like the malaria test kit. So these are only 2. If you get one with 3, that is an invalid result. I don't know the one that is tested. So the quality control, of course, I've talked of the control line. With this an IQC measure that should be able to tell you that the process is going on well. So if you don't have the test line or the control line, then you should be able to know that this test kit has not been used. It has not tested anything. So the test line is used for procedural control and shows only that the active ingredients or main components of the strip are functional. I've been thinking, why we had introduction of both of the dual kits, the HIV and syphilis. From analysis, it was reported that most people were doing HIV testing and syphilis testing was not being done. Or you go to the labs, there are stockouts. So HIV is done, syphilis is not done. So they incorporated HIV and syphilis dual. From my thinking, moving forward, I'm trying to imagine now that we have a triple threat, and we're trying to do a triple elimination, that in future, I don't know how soon that future will be, we might have a test kit, or maybe it's available but not rolled out, that is able to test HIV, that is able to test syphilis, that is also able to test hepatitis B. So I think this will help to bridge the gap of stockouts that exist in our facilities, because some of them are for things that are beyond staff control. And the only way to ensure that we eliminate these patients, our mothers going without testing, is availing the triple test kits. I think constant supply of these test kits are also very important. So NASCOP, I think, with the partners, should at all time ensure that these test kits are available. So documentation, registers, and reporting per se is not done at the lab, except for, I don't know, I think private facilities and FBOs. But majorly in our public facilities, it's domiciled in the ANC. So that's why the screening and positive results are recorded in our MOH 405, that is the ANC register, version 2023, and there are reportable elements in MOH 731. We are currently not collecting hepatitis B virus data in MOH 333. That is the maternity register, and MOH 406, postnatal clinic register. So I think that should mark my second last PowerPoint, as I acknowledge the Laboratory Medicine Society of Kenya for granting me the opportunity to present to fellow colleagues, NASCOP for the training they had and rolling out the BioLine test kit and incorporating hepatitis B virus testing in ANC. Our attendees from across the globe, I know people have joined across the globe at different time zones. I acknowledge you for having taken your time to attend this webinar. Otherwise, thank you very much for granting me the opportunity. I will ask my co-host to proceed from there.
Great. Thank you very much, Mr. Nation. This is wonderful, and it's a great presentation. I can see many of the attendees are actually appreciating, and they are commending your good work, well-researched, thought-provoking, and full of knowledge. So thank you very much. So at this juncture, we welcome questions. And if anyone has any question, you are free to use the chat box. And you are also free to raise your hand. I will be able to see it from this end and grant you the access to speak. So feel free. There's some of the concerns that maybe you'd like to ask, and the way you feel that they can come out clearly is for you to talk. So you have that chance. So now the first question that I'd like our presenter to respond to is from Betty Chelangat. So Betty Chelangat is asking this question, is saying, Why is it that when blood is screened for transfusion, you easily get hepatitis B virus, but the same pint tested with rapid test kit, you get negative? Kindly elaborate on this, Mr. Nation. Let me read it again. Why
Yes.
is it that when blood is screened for transfusion, you easily get hepatitis B virus? I think you're saying that when it is being, when blood sample is, I'm not a sample, when blood is supposed to be used for transfusion and it is tested, most of the results usually become positive. But
Yes.
you take the same pint to be tested using a rapid test kit, you find that it is negative. So there's some discordant results. Now, would you elaborate on this? Over to you,
Yes.
Mr.
Yes. I'm able to elaborate on that. I think what the kind of screening test we have for blood materials, that is the transfusion blood, or blood that is meant for transfusion, the test kits are superior. We have superior test to these are rapid test kit. So rapid test kit is only able to test, just like I'd said, we have kits that are able to test for the DNA itself. Yes. So these are this is the type of testing that is done for our donated blood. However, for our rapid kits, these ones are screening kits that are not able to give results for a recent infection. I don't know whether I'm getting it clear, or I'm giving it rightly, or maybe to make it with a lot of clarity. We have screening kits. Remember that when an antigen gets into our body, they elicit antibody reaction. So it's the antibodies that are the antibodies that the body is responding to is what these kits are able to test. And normally it takes time. Whereas the kits that are used, or the testing procedure that is used in blood banking, is a superior one that is able to test for the DNA. And just like I had said in my presentation, that in DNA testing, you are able to test, you are able to get the antigen, the testing, the virus itself within 7 days. I think that is now clear.
Okay, thank you very much for that. Another question. Someone is asking that can HBV be transmitted through sweat when bodies are in contact with the infected person?
Hepatitis C or B?
HBV, hepatitis
HBV.
B.
HBV is bloodborne, purely bloodborne. As I'd said, it's bloodborne. Unlike the other hepatitis A and E that are contaminated through contracted through contaminated food or water. These ones are bloodborne.
Thank you very much. I think that is well tackled. So the answer is no. What are the diagnostic methods for infants and children less than 18 months? What are the diagnostic methods for infants and children less than 18 months?
I think this, unlike HIV, okay, we normally have HIV testing below 18 months, we do DNA, PCR, yes. Yeah, this applies also to our, actually to all these viruses, because if you do a rapid testing for our newborns, then the actual results that you're going to get are from the mother and not from the child itself. We understand?
Great, that's good. So you detect the antigen itself. Now,
Yeah.
how safe is the screened blood for transfusion? Betty Mende is asking this question. I'll just read it the way it is. How
Yes.
safe is the screened blood for transfusion in case the donor had acquired HIV virus within 24 hours before donation? I don't know if
HIV
Mende
ama
meant
HPV?
HBV, but I think it is HBV. Mende, we are looking at HBV. So, Mr. Nation, kindly just respond um, concerning HBV virus acquisition within 24 hours before donation. Maybe after that you can say something about HIV. Okay, over to you.
Okay. Unfortunately, our testing capability is not able to detect both hepatitis B and HIV at 24 hours post-exposure. Like I had said, the earliest of, I think, of the machines we have, the fastest and the earliest they can detect is beyond 7 days. So I can authoritatively say that if you are exposed 24 hours and the machine is not able to detect, then for obvious reason, you will be able to transmit it. However, we are undergoing, we have the how do we call it, the slogan? Is it a slogan of U is equals to U? So when the principle of U is equals to U, that is undetected is equals to untransmittable. If you cannot detect it, you cannot transmit. So this also brings me back to another the same thing, but a different scenario. So if you are not able to detect it, it means the viral load is very minimal. I want him also to understand. I hope he's a him or maybe she, to understand this principle also. You are not able to detect. It means you are not able to transmit. And the principle behind this is the viral load is still low. Remember, if we have low viremia in HIV, in hepatitis B, then you are not able to transmit it. And also, I think there's a presentation that I must have overlooked. Even those who become, those who acquire the hepatitis B virus, those who are transmitted to, that the immune response is able to clear it by itself over some time. Not all HBV infections are actually advanced to diseases. The immune response is able to clear it. So I think from those two instances, my colleague is able to understand.
Thank you very much. Stephen Kibet is also having a question here. And the question reads, how do different serological markers help in differentiating stages of HBV infection? How do different serological markers? We tackled the serological markers, the ones
Yes,
that, for example, the
the
hepatitis B surface antigen,
surface antigen.
HBE, yes, all
Yes.
that. So, how are they assisting or helping in differentiating stages of HBV infection?
Yes. So I want to, like I remember saying, hepatitis B surface antigen is the first marker, and it appears 1 to 3 weeks before the onset of symptoms. So this should be able to tell you when you are using hepatitis B surface antigen. Then, if you see it turning positive, unlike anti-hepatitis BS, which appears 1 to 3 months after vaccination. You see, when you find anti-hepatitis B surface hepatitis BS, being positive, then it should actually tell you that this person was vaccinated 1 to 3 months ago. So there are different stages. Their appearance or testing at different stages shows you the time at which they are actually found in the blood. Because you won't find them, mostly you won't find them, all of them at the same time. So they have different stages. Like anti-hepatitis B, C, IgM. This one shows marker of recent infection. Yes, so they stage differently, and the markers shows infection differently at different times. I think I've answered.
Excellent. Thank you very much. We have Professor Tom Were, who
Yes,
has a question. I think, yes,
he's
it's
my
a lengthy
supervisor.
one, and I would like him to at least have the pleasure of talking and just voice it out. I think, Prof, if you are there, you can just unmute and um, voice out your concern. You are welcome, Professor Were.
Thank you. This is a very excellent question with regards to what we do comes to info.
Okay, Prof, your mic is a bit far. I don't know if you can just come closer so that we can hear you clearly.
Can
Kindly.
you now hear me?
Okay,
Hello.
proceed.
Yeah, so I had an excellent presentation from the young man, and I'm very happy about it. I have some 2, 3 questions. One is about the these are basically those infectious diseases acquired from the mouth. So the question was, why focus on hepatitis B virus, syphilis, and HIV when we have that whole list of infections? And then number 2 was with regards to the 5-panel marker. I think I've listed them: the surface antigen, the total antibody, and so on. I've used the 5-panel marker in detecting hepatitis B infection in those people who are at highest, specifically the substance users. And it gave me good results to be able to stratify the individuals into different risk groups, and particularly when you're on HIV patients. So my opinion would be that what we are doing is good, but we also need to move on by introducing some of the multiple panel markers, just as the way you suggest that you can have some kind of RDT, which is multiple panel, but in this case, picks up probably all the coaches in one case. And then, of course, the others were comments about why we can't get the hepatitis B infection through sweat. I've just said that unless the sweat is contaminated with blood, an example being those people engaged in contact sport, then that blood contaminated sweat comes in contact with an open skin or mucous membrane, then there is a possibility of infection. And the other comment was on testing in illness. So we are saying that for the high risk children, that children born of hepatitis B positive mother, we start to use about
We've lost you, Prof.
Oh, you have lost me. My internet is not so clear, but I've written the comments on the group. I think we can all follow.
Okay. Thank you very much, Prof. Thank you very much for the comments and for also elaborating on some of the areas. We value that. And I think, Mr. Nation, you can just also respond to some of the concerns, and then we
Yes.
move to the next. All right.
Yes. Thank you, Prof. Prof is my postgraduate supervisor. Thank you for coming in and shedding more light. I want to respond on why the triple of hepatitis B, HIV, and syphilis. So I think through NASCOP that has guided us over time, HIV, syphilis, and hepatitis B have been seen as a threat to the neonates and also to the to the children who are born, simply because of the disease, the advanced disease that actually come after post infection. So when one is infected, the mortality and the morbidity of these three diseases, actually three, how do I call it? So the hepatitis B virus, the HIV virus, and syphilis, the mortality and morbidity that is associated with them has actually made NASCOP and other intervening bodies that are present that actually look for the welfare of children and mothers to focus their effort on the three. So that's why, and actually depending on the prevalence. So others, their prevalence must be low, and then the level of this disease becoming chronic is also high. And the fact that these diseases are preventable through prophylaxis and also through testing and then giving prophylaxis and also vaccine and the rest, it therefore becomes manageable. So that's why the government is keen on a triple elimination of HIV, hepatitis B, and syphilis. I think others were comments and
I think that's wonderful, Mr. Nation. We have Loba Loba. So Loba, you have so far 2 questions. If you are here, you'll be given time just to also have a chance to speak. You can just prepare yourself. But before you are given the chance, Mr. Nation, you can respond to these 2 questions. Both of them are talking about vaccine. The vaccine. So how long does the vaccine last in the body? Does it need a booster vaccine? And again, another one is if a pregnant woman was vaccinated with HPV, with HBV, sorry, if a woman is vaccinated, she should be vaccinated against HBV for her own safety. Is there any side effect to her or her baby? So this by a question by Catherine Linger. Over to you, Mr. Nation. The first question was about the timeline. Does the vaccine need a booster? And another one is if a pregnant woman, who has already been vaccinated against HBV, is there any side effect to her or the baby? Over to you, Mr. Nation.
let me start with the booster. I think we all appreciate the fact that some of us, when we were joining medical schools, we were vaccinated against hepatitis B. And I think for me, I received 2 jabs. But then I'm reliably informed that this is not lifelong. One needs to get boosted. If I'm wrong, then I can be corrected. So even this, the child, once given within 24 hours, there's a vaccine that is given. I think I'll not be wrong unless I research widely, because I'm not well versed with the vaccination schedule at the ANC. But giving booster moving forward is not a sin. Then I haven't seen any documentation of those that are vaccinated against the pregnant or the breastfeeding women that are vaccinated against HBV. Any side effect that has been reported, that unless I also confirm, but I haven't heard of any. If there is, I'll gladly appreciate receiving.
Okay, thank you very much. Loba, you can unmute and speak. Okay, it seems Loba is not able to speak, but again, we'll proceed. So quite a number are appreciating your presentation, Mr. Nation. I can see Mr. David Kaino is saying this is very educative. It's a very educative presentation. Maureen Mutuku, good presentation. Quite a number are appreciating. Joshua Wandiga is saying that this is a good presentation. Virologist Kooko Nation. So you can also respond with some loves, some reactions to this. You can just do the likes. I think our presenter will be able to see and actually acknowledge that we are together. And so there are more questions, and time is also not on our side, but
There's a
we are doing our best to actually attend to as many as possible. Mr. Nation, you wanted to say
there's,
something?
yes, there's actually a comment that I've seen
Okay, please
asking
go
to
ahead and address it.
please revisit the slide showing the quantity of blood to draw and how to do it. So I think, just like I said,
Is it the procedure?
I think the procedure, the quantity actually, the quantity of blood I said is 100 microliter, and the pipette that is given is actually graduated. So the 100 microliter blood that is needed for the testing is actually, you are able to tell that you've drawn the 100 microliter of blood, either through whole blood, the whole blood, plasma, or serum. So it's graduated actually. There's a mark that is quite conspicuous on the pipette that should be able to guide you. And how to do it? I think how to do it is quite similar to, if you remember doing DBS, the dried blood, the DBS for the EID PCR. So the way you draw blood for whole blood using that kind of pipette, micropipette, is the same way you use it to dispense and draw blood from for this particular BioLine test kit. Yes. Do we have a kit for testing HBV, Janet Ndirangu? Yes, we have BioLine. I've mentioned that.
Thank you very
BioLine was
much.
rolled out. Yes.
Good. There's some announcement that I would like to pass across, which is very important. Quite a number are asking about their speedy points and certificates for the previous session that we had yesterday. So kindly take note that both the CPD point and the certificates will be awarded tomorrow. And so we call for your patience. Even today's presentation, we call for your patience, and we are also engaging you on our WhatsApp platforms. Kindly keep checking. Let's be patient on that. You will receive all the information, all the points, and everything will be okay. Number 2 is about the information that you use during registration. Ensure that you key in correct information, especially the Cambridge TB registration number and the ID number, as well as the email address. So those are the 3 important information that we need. And your name is important as well. So ensure that all that are correctly entered. And also, if you need the CPD points, ensure that you pay the 50 shillings only. So we'll be glad to serve you. We'll be having our webinars all through. Tomorrow we'll also have our webinar. So just stay put. We are here to ensure that at the end of 20th, as was provided by the Cambridge TB, you will be having at least 50 CPD points so that you renew your license at ease. So just stay together with us and be sure, or rather just continue with the other things. Be sure that you will be able to attain the CPD points as required by the board. Now, there's one more question. Due to time, I would just read this question out. It is not concerning the HPV, but I think we can also brainstorm about it. He's saying that Calvin's Oude is asking, is gonorrhea being tested using VDRL rapid kits that is used in ANC profile? It's about gonorrhea being tested using VDRL rapid kits. Just a quick response to that, Mr. Nation.
No.
The answer is no.
The answer is no.
No, thank you very much, Calvins. The answer to that is no. So at this point, I really appreciate every medical laboratory practitioner and all the attendees who have managed to participate in this wonderful presentation. And Mr. Nation, I would like to give you around 30 seconds or 1 minute just to give us a parting shot or just a statement to end this session. So we are at the conclusion point, and so you can just tell us something about the presentation or just something that you'd like to stress concerning the today's topic, or rather something that you'd like to inform the medical laboratory fraternity. So over to you, Mr. Nation.
Thank you very much, host. I really want to insist on the fact that hepatitis B virus is with us. I've seen quite a number of pregnant women and breastfeeding women being infected. They don't know. I had a case for confidentiality issues. That patient came all the way from Mombasa, was told to come and see kienyeji, only to test and find that it is hepatitis B. So this is there with us. So I would really urge us, if there is no supply that is being given, the stockouts, with their stockouts by from the NASCOP and KEMSA, kindly advise the facility managers to always include hepatitis B test kits in screening of our mothers. Then one thing I really want to insist is that the BioLine hepatitis B surface antigen testing kit has no buffer. Kindly do not take any buffer. Buffer are specific. I hope we are all scientists and we understand. Buffer are test specific. Once you put the adequate volume of 100 microliter, the sample will flow and give it 20 minutes. Do not read those results after 20 minutes. You will get false results. Otherwise, thank you for granting me the opportunity to be here. Thank you, colleagues, for having confided in me. And I say viva, viva, viva to medical lab profession.
Viva, Nation Viva. Thank you very much for that. To our attendees, the medical laboratory practitioners, we appreciate your presence here. So on behalf of LMSK, feel appreciated. We welcome you for more of our webinars. more of these sessions, we usually meet at from 3 p.m. to 4:30, and as you can see, it's exactly 4:30. We are past 1 minute. So at this point, allow me to bring this session to a close and wish you a wonderful evening and a weekend ahead. So as you start your week tomorrow, we'll also have our webinar tomorrow from 3 p.m. So stay with us and join the meetings. Thank you very much and enjoy your evening. Thank you very much also, Mr. Nation, for the wonderful presentation.
Karibu.